Let's do the head-to-toe examination. This head-to-toe examination is basically going to be for trauma format, so that we could focus on a kill zone here, anywhere from this mid-abdomen where all your solid organs are that could bleed out, and up, because we have a lot of large target organs here in the upper torso, long as the neck and head. This would be more of our focus exam for a critical patient. What we're going to focus on right now, though, is a detailed head-to-toe exam. You start off at the head, you palpate the scalp and the head for hair, and you're looking for any type of deformities, contusions, abrasions, lacerations, punctures, swelling, edema, looking at your fingers for any blood, and you're basically palpating and trying to feel in these areas of the cranium. You feel in the occipital region, the back, the parietal region, the temporal regions, any blood, any of those type of injuries or soft tissue or bone injuries that you can see. Particular to notice around the back of the ears for those kind of battle signs, or around the orbits here and eyes for any raccoon signs. You're going to continue to palpate the facial bones. You can palpate the facial bones over the cheekbones and then the lower jaw bones. So you get the maxilla, mandible, the TMJ. We can start with the pupils. You'd have the person look upright. You have them look directly at your nose, because you're going to tell them you're going to shine a light in their eye. You'll shine a light in one side, and you just want to catch it indirectly off the other side. Then you're going to tell them, okay, go ahead and open up their eye. Look at my nose again, and you're shining indirectly. You're looking at both sides of the eyes to make sure that the pupils constrict to light and then dilate when you take the light off. And this means if you're stimulating this side of the eye with the light, you should see the constriction on this side to accommodate for the light being shined in this eye, and vice versa. You also have the person look at your finger and follow or track the eyes, their eye movements to your finger. We can come down and take a look at the nose and see if there's any type of deformities, septal deviations, any epistaxis or nosebleed. You check the ears again for those types of battle signs, any autourea that's coming out, any kind of bleeding. Into the mouth cavity or oral cavity, we're looking at the dentures and teeth, the dentation, and we're looking at the mucosa, we're looking at the buccal lining, we're looking at the gingiva, we're looking at the tongue, the uvula, the back of the throat, if there's any type of obstructions or secretions in there. We're going to have the patient open up their mouth and stick out their tongue to see if their tongue goes in any deviation. We continue down with the palpation along the neck to check the posterior side a little bit for any type of tenderness, midline or lateral tenderness. We can feel for any kind of step-offs or misalignment of the cervical vertebrae. You look at that anterior portion of the neck. Now we're looking at for JVD, any tracheal shift, any type of misalignment. And we're listening to, when they're talking to us, to listen to the voice quality. We come down to the chest cavity or the upper torso. We're palpating and running our hand along the clavicle bones here to make sure that there isn't any misalignment or fracture along this clavicle bone line as it runs up to the scapula here. The shoulder blade and the scapula, the acromion, and then down here into the sternum. As we come across the chest, we're looking and inspecting visually to see if there's any abnormal deformities or rise and fall in the chest wall. We'd go ahead and now listen to the chest wall by taking our stethoscope off, looking at the rate, quality, and rhythm of respirations. We're checking lung sounds bilaterally from side to side. Mostly over this area, we're hearing more like bronchial type breath sounds because that's the larger airways. We're going to continue down towards the base and the lateral aspects so that we can hear more vesicular lung sounds. As you're listening, you're having the patient take a breath in and out as you listen for those breaths. Now, they may get a little fatigued or tired, so you watch them as you do the exam. We continue down and we can go ahead and palpate anterior-posterior stress of the chest wall. So I'm testing the sternum and I'm pressing on the side or the back. And then lateral aspects, as I press along the rib cage here, where the angle of the ribs come, I'm trying to stress to see if there's any misalignment or deformities, and as I feel, I'm looking for any type of abrasions, contusions, punctures, lacerations, burns, swelling, and any kind of discoloration or ecchymosis. In this case, for the lungs, I'm not looking specifically for eviscerations, but I'd be looking for flail segments, subcutaneous emphysema, and the like. My lung sound should be clear. I should hear air movement throughout the entire chest. If I should hear anything else, then that would lead me to something like some kind of abnormal breath sounds. We're moving on to the abdomen. As I look at the abdomen, I like to make sure that the shape is normal, that there's not any abnormality in the contour of the abdomen. In some people, it may be slightly obese. Other people, they might be gravid and pregnant. There may be other surgical scars as we come down through the upper torso and going down to the abdomen. Abdomen is broken up into our 4 quadrants, can be broken up into even more. But basically for us, we just kind of keep it that simple. It's delineated here at the umbilical line, and we run straight up and down to the midline. We're going to check the 4 quadrants. So as we look, the contour is fine. I don't see any ecchymosis or any kind of discoloration. In this case, it would be evisceration, where the part of the organ or the intestine has protruded out from a miscommunication or an opening within the abdominal wall. As we palpate in the order of least pain as reported from our patient. We can just start here. I'm going to start up in the upper left quadrant. I'm going to use this hand to feel as tactile stimulation, and on this hand, the top hand, I'm going to use for pressure. I'm going to use some light pressure to palpate and feel around in that upper left quadrant. And I'm going to ask the patient if they experience any discomfort by watching their face. I'm going to move down to the lower quadrant here. Palpating again with the top hand is putting the pressure, while the bottom hand is for tactile stimulation, tactile touch and feel. I'm going to palpate across on the lower right and then the upper right. You have to remember that the organs that lie within the area that's being evaluated. We can then listen to some abdominal wall sounds. You should hear what's normally just these gastric sounds. If it's silent, then that's something that could be noted that could be quite serious. We should hear at least a few sounds to teens, that type of gurgling and churning sounds, because most bowel is quite active. It could be hyperactive, where it's just constantly churning, and that would be more of like when we talk about medical cases. All right, look for any type of rebound tenderness as we press. We relax and rebound. We'll see that the person kind of winces and jumps up. There could be some referred pain when we do this rebound tenderness. What we're doing is pressing down and lifting away real quickly to see the reaction. This is caused by peritonitis, or inflammation of the peritoneum, a lining of the abdominal walls and visceral linings. If this causes the radiation of pain and the area of injuries here, or area of pain is there, that's what we call referred pain. There are other types of tests that we can do. We can tap the soles of the feet and see if that causes any type of irritation into the abdominal wall. As we palpate, we're noting for any kind of masses, we're noting for any type of tenderness, and we're also looking for any type of guarding where they kind of press up or make their abdominal wall tight so that we don't press too deeply. We can also press in this upper right abdominal cage here, just under this rib margin, the hypochondrial region. Right underneath there, we're going in and light palpation, and then we'll have the patient take a breath in. And as they're taking a breath in, the diaphragm comes down and pushes on the organ here, which is the liver. And sometimes if the gallbladder is irritated, they'll stop breathing because as the organ drops down with the diaphragm, excuse me, yes. So as the organ drops down, they're gonna, the fingers here are gonna kind of irritate the space between the liver and gallbladder. All right, so that would be more medical. All right, so we're also looking for discolorations around the periumbilical area and anything on the flank sides. As we come down to the pelvic girdle, we're gonna put anterior, posterior stress when we press on the pubic bone and the tailbone area, coccyx, and then lateral stress as we stress on the lateral aspects of the hip bone. We're not gonna tend to rock the patient's pelvic girdle. We can check the lower extremities as we come down, and we're going to check for PMS as well as intact bone and function. Again, you can cut and expose for your entire exam. So we're going to check as we come down. We can check the perineum and the groin area for any type of priapism or incontinence, any gross bleeding. Here we check the hip, see that the hip is easily maneuverable. We can check the range of motion, but first let's check to make sure that we have some anterior-posterior stress on this bone. So as we're pressing down, I'm trying to press side to side to make sure that this bone doesn't move this way, and I'm pressing anterior-posterior stress so that I see if the bone would have any type of movement or break upwards or downwards. So stress again, come down, check the knee a little bit, check down the lower half of that extremity, and then down to the ankle bone. Again, we can check for these motions by moving the hip and knee and ankle to see if we have good range of motion, okay, or any deformities. We'll do the same thing on the other side, and then we check the distal parameters here by checking the pulse. This would be the dorsalis pedis. We can also check the posterior tibialis. We're going to check the capillary refill on the toes. We can strike the soles of the feet to check for Babinski, and that would be our type of neuro check, and then we can check our distal pulses. Can they feel me touching? Can you feel me touching? Can you feel me touch me? What leg am I touching now? What leg am I touching now? This would be an exam for the lower extremities. Again, looking for decap BTLS. As we come to the upper extremity, we'd cut and expose again. And we can kind of start at the upper humerus. We would check one side, the anterior-posterior stress and lateral stress, test the elbow and the range of motion. We can test anterior-posterior stress here on the arm. And we'll test both sides, and then we go ahead and have them cross their hands, and we'll cross and check for grip strength. Could you squeeze my hands both sides as tightly as possible? Okay, great. Now I'm going to touch, and I'm going to ask you, what hand am I touching? What hand am I touching? Can you tell me again? And what about now? And check for the pulse. So again, we're looking for decap BTLS on the arms and extremities for any type of fractures, soft tissue injury, or musculoskeletal type injury. The last part is rotating and rolling them over into the back. Now, as we check the back, you're going to make sure that you check, this person, if it's in trauma, they're going to be inline mobilization and a collar in place, and the neck should have been checked. We're going to check the back for any type of discolorations, deformities, any type of protrusions. At this time, we could even have assistant help hold them up so that we could listen to the breath sounds on the posterior back. Looking for any type of incontinence as we go down, making sure that the spine line is midline and there's no decussation, step-offs, or it's just not misaligned in any fashion.